Good afternoon. I'm Dr. Gutiérrez Bonet from Yulgonan Eye Hospital, and I'm going to present a study of the macular choroidal thickness profile in keratoconus patients using Webster's optical coherence tomography. Keratoconus is the most frequent of all the corneal ectasis disorders. It affects affecting 300,000 people in the United States. The conical shape of the cornea is going to produce a progressive myopia and astigmatism. This illness is typically diagnosed during puberty, and it can progress until the 4th decade of life, when it usually stops. The stroma of these patients is less rigid, so it's going to cause a corneal deformation. Given that the origin of the keratoconus is based on an alteration of the collagen fibers, we could expect modification in other structures that contains collagen fibers, such as the choroid. So the purpose of this study is to determine if patients suffering from keratoconus in its different stages present alteration of the choroidal thickness profile. The inclusion criteria of this prospective study were a clinical and topographic diagnosis of keratoconus and also a proper quality of the images. Those patients having any history of ocular trauma, ocular tumor, or retinal diseases were excluded, and also those patients who had an axial length longer than 26 due to its known relation with choroidal thinning. A total of 102 eyes were included in the study. We performed a complete ophthalmological examination and some complementary tests. The first one was pentacam to analyze the topographic characteristic of the corneal. To measure the axial length, we use the Eye-All-Master 500. And to take the images of the choroid, you use Triton Webster's OCT. Our sample was compared to age and gender matched healthy controls. We manually measure the choroid under the fovea and in 8 more locations using published protocols. In this graph, we can see we can see the choroidal thickness profile in normal controls. That it's that it's in blue, and also in the choroidal thickness profile in keratoconus patients that are painted in orange. We can see that there is a very big difference between the choroidal thickness in normal patients and keratoconus patients, because the choroidal thickness profile in keratoconus patients was much thicker. But we found one exception. Those patients older than 45 years old leveled down with those patients with the same age. In this table, we can see the difference between the choroidal thickness in healthy population and keratoconus. And we can see the significant differences. But we couldn't find this difference in the location nasal 2, probably due to the sample size. In this other graph, we can compare the choroidal thickness in function of the grade of keratoconus. In dark blue, we can see the normal healthy controls, and in light blue, the grade for keratoconus patients, and there is a very big differences between both. Here there is an example. This is a grade 4 keratoconus with a Kmax of 73 diopters, and we can see his enormous choroid. He also had a keratoconus in his other eye with a grade 2 keratoconus, so it was a smaller one. He also presented a very big choroid, but much smaller than in the other eye. So we managed two theories to explain our results. The first one talks about the collagen. The main component of the stroma of the choroid is the collagen type 1. And we can also find this collagen in the media and adventitia of the vessel walls. Given that the choroid is mostly made of vessels, modification in the collagen could be translated into structural variations. But this theory cannot fully explain our results, because we have already seen that those patients older than 45 has an almost normal choroid. So if we've got a collagen alteration, we have to have an alteration in the choroidal thickness profile stable with age, or even be worse during the time. The second theory talks about inflammation. In this graph, we can see the normal evolution of the choroidal towards a progressive thinning. But there are some exceptions, and we can see an increase in the choroidal thickness in some inflammatory diseases. For example, bowel disease, Behçet, psoriasis. This group of authors, Maruco et al., published that in Arada disease, in the acute phase, the choroidal thickness is going to be increased. And after started the treatment with corticoids, the choroidal thickness is going to turn back to normality. The latest theories about keratoconus talk about an inflammatory component. It has been proved that in the tear film of those patients there is a high concentration of some pro-inflammatory cytokines such as interleukin 6 and metalloproteinase 9. It has been also proved that those patients suffering from keratoconus who receive a treatment with cyclosporine, if we evaluate the concentration of these pro-inflammatory cytokines before and after the treatment, we can see that there is a decrease of the concentration, and also a stabilization of the cone with better keratometry. So this inflammatory theory can completely justify our results. Keratoconus is a progressive disease that it's going to stop around the age of 40. As inflammation disappears, the choroidal thickness will come back to normality. To conclude, the choroid of keratoconus patient is thicker than the choroid of healthy controls. This rise tends to go down to normal age, gender, matched values at 45 years of age. From there on, keratoconus is supposed to reach stability. This supports the theories about an inflammatory origin of keratoconus. Thank you very much.